Hello, I'm Dr. Omar Bey, and welcome to OBHealthy Physicians Health Network. We're a group of physicians that are here because for basically two reasons. Number one, to improve the health of people of African descent. And number two is to encourage young Black males to go into medicine because it's a worthy profession and we need you there. So any young male out there that's even thinking about medicine, pursue, please pursue. This webinar is every second Saturday at 1 o'clock. And please, sign on, tell friends about it, and most importantly, type in your medical questions. And do me a favor, type them in early because sometimes people type them in 5 minutes before we're about to end the show and we don't get a chance to get to them. So if you have a question, type it in early so we can answer that question. If you want to see any of our past webinars, all you have to do is go to OBHealthy's website, obhealthy.com, and go to the physicians page, or just scroll to the bottom of any of the pages and hit the YouTube sign. All of our past webinars will come up. So many good medical topics geared for the people of African descent, and the education is wonderful. So just go and listen to those. It's so important that we understand our medical problems and how to care for ourselves appropriately. Subscribe to that to the YouTube because that allows us to maintain our videos and our webinars on YouTube. The most important thing I can say today is please do not change any aspect of your medical care before you consult your physician. Only your doctor, truly only your doctor can best care for you from a medical perspective. All righty. I think I've covered everything. Right now, the docs will be signing in. Several docs have texted me and said that they will be here. They're in the hospital making rounds. And as soon as they get a chance to break away, they will come and be a part of this webinar. But right now, what I'd like to do is I'd like for each of us to introduce ourselves, the ones that are here, and we're going to get going because we have excellent topic today and an excellent person delivering that topic. We're going to rock and roll today. Dr. Mazer Ali, please introduce yourself.
Hi there and welcome. My name is Mazer Ali. I'm one of the GI, I'm a GI specialist and I work, I'm on the left coast in Southern California. I work at Scripps Clinic in San Diego, and I've been a part of this network. I've been privileged to be a part of this network and colleagues with Dr. Bey and Dr. Court now for about a year, and just happy to be here, privileged to be a part of this great group of physicians. And we all share some very common interests and goals of making sure that we can try to improve the lives of others. Today, what we're going to talk about are some GI or gastroenterology-based subjects. And, Dr. Bey asked me to touch upon two particular topics that are very common and are becoming a little bit more common here. And we'll talk about the conditions called irritable bowel syndrome, which is a condition of what I call the function of the gut. And the other condition that we're going to touch upon is something called the inflammatory bowel diseases. And that includes particularly diseases such as ulcerative colitis and Crohn's disease. And there's a lot of overlap in between that. And a lot of people may suffer from GI symptoms and they may not know what they've got. So I'm hoping that with some of the discussion that we'll have today, it'll give a little bit more clarity. I see some questions that have come in through the pipeline, and I'm happy to answer some of these questions as well about prevention of bowel obstruction and things like polyps. So, with that being said, we do have I do have some slides that I will be presenting that'll be popped up here very shortly. Right. But you know what,
Dr. Mazer, let me introduce everybody else, and then we're going to jump into you. All righty. And not to cut you off because you got a roll going, brother.
No problem.
Sounds good. Sounds good. I'm so excited. Dr. Court, tell us who you are.
I'm Dr. James Cord, a graduate of Howard University. My practice is internal medicine located in East Orange, New Jersey.
All right.
Thank you.
Excellent. Excellent. We have Dr. Jordan Garrison. Jordan, you're on mute.
Good afternoon, everyone. My name is Jordan Garrison. I am a board-certified general vascular and bariatric surgeon. Presently, I practice in Hackensack, New Jersey, and my practice is limited to the diseases of veins and the treatment of venous disorders.
Excellent. Excellent. And Dr. Kendall Sprott, please.
Yes, I'm Kendall Sprott. I'm a retired pediatrician. I studied at Morehouse College and then at New Jersey Medical School, and did critical care pediatrics for 15 years and academic pediatrics as a hospitalist in general pediatrics.
Well, thank you very much. And I'm Dr. Omar Bey, pulmonary critical care physician with a subspecialty in nutrition. All right, Dr. Mazur, I'm going to ask you some nutrition questions too, so as we go along. But you know, the thing of it is, you talked about irritable bowel syndrome, and just understand, be patient with us because Dr. Mazur does have some slides, and we're going to try to bring those up. Our technician is working with that now. But irritable bowel syndrome, just give us some understanding, because I know a lot of people suffer from this. Give us some understanding of what it is.
Sure. So what we know is up to a quarter of people suffer from some elements of an irritable bowel. Now, an irritable bowel syndrome is when the function of our digestive system, function meaning the movement itself, there's some sort of a disarray in that, where either your bowels may move a little faster than they should, or they may move slower than they should. And this can affect things like digestion. It can cause symptoms of diarrhea. It can on the other end of the spectrum, cause constipation. It can cause abdominal bloating or just increased gas, particularly after a meal, feeling like you get very gassy, bloated, and just distended, like your stomach just pooches out. It could also cause abdominal pain. A lot of times people may suffer from pain in the lower parts of their belly right before having a bowel movement, or with some relief thereafter, or just what I call a spasm, where people can also develop just very sharp pains in the abdomen. And these are all symptoms that create this constellation of what we call irritable bowel.
Excellent, excellent. You know, I was thinking, you know, is the location of the pain important? You know, as far as your stomach or your abdominal region is concerned, what about the location? If it's upper part or lower part, or does that give you an indication that a patient may have one problem or another?
Sure, it certainly can. And not always, but most of the time, when people suffer from pain, what I call in that peri-umbilical area, just around the navel, that can be a very common place, or even in the lower left part of your abdomen, where people can suffer from cramps. Now, there are other conditions that can also mimic an irritable bowel or be completely different than an irritable bowel. There's something called diverticulitis, where this is what we call inflammation of what we call a diverticula. And these are little pockets that can develop in the colon. As we age, we kind of all develop them. And, you know, the other common thing that I may notice is when people suffer from pain in the right lower part of their abdomen, the other thing that we always are concerned about in that scenario could be an appendix, the appendicitis, or inflammation of the appendix. Now, when patients have maybe abdominal pain in the upper parts of the belly, particularly right in the middle upper part of the belly, sometimes it could be an irritable bowel, but also it could even be related to what we call reflux, or increased acid in the stomach, and that can cause an issue. And then the other is whenever there's pain in the right upper part of your belly, you know, again, it could all be part of an irritable bowel, but the other things that we think about in that particular region of the stomach is the gallbladder. Things like gallstones, causing cholecystitis or inflammation of the gallbladder.
Excellent, excellent. You know, there's questions coming in already. And before we bring the slides up, let's answer some of these questions. Number one is, how do you prevent small bowel obstruction from occurring again? Again, so obviously they had it once.
Sure. Yeah. And these are very tough situations because bowel obstructions, there are different reasons why somebody may have a bowel obstruction. A bowel obstruction could occur secondary to somebody having a surgery and having scar tissue or what we call adhesions in the abdomen. And it can make the bowels, either the small and most of the times in this scenario, the small intestines, there's scar tissue that puts kinks in the small bowel, and that can cause kind of where there a kink where it can cause a blockage. And sometimes despite our best efforts, it's hard to prevent these. They can occur naturally over time. What I always do recommend, though, is things that we can try to do to help are things like fiber in the diet. Fiber sometimes can get a little confusing, but fiber is a great regulator of bowel for a couple different reasons. It helps to congeal stool or bowels where people can have more formed regular bowel movements. Now, sometimes fiber, especially fibers that are a little harder, what I call insoluble fibers, these could be a little bit more challenging in these scenarios because those types of foods are harder to break down, and you want to have things that could break down much an easier way in the setting of something that's narrowed or kinked. But sometimes fiber can help in at least allowing for more regular bowel movements. But again, it's variable given the circumstance of how somebody may have developed the bowel obstruction.
Interesting. We have a lot of questions. You're a hot topic. You know that. You got a lot of questions coming in. So let's do some more of these questions because they're coming in really fast. What can you do to prevent reoccurring polyps?
So polyps, again, another very common thing that can develop.
Explain what a polyp is first.
A polyp is a growth. It's a little growth that we detect in colon cancer screening. Now, we have recommendations for men and women over the age of 45 or 45 and older to undergo screenings screening for colon cancer. Very similar. We have recommendations to screen for things like breast cancer in women. In colon cancer, this is the third most common cancer and it can occur in both men and women. So our recommendations are for screening. And the way we screen include things like a stool test. There's a blood test, or not a stool blood test, or what we call a Cologuard test, which checks the stool DNA. And then the other thing that we can do is a colonoscopy, where we actually go in with a camera and take a look. And we look for things like cancer. But one of the precursors to a cancer are polyps, and these are little growths that can occur. And not all polyps turn into cancer, but some potentially could. And they're very slow growing. You don't feel them. And over the course of 10 years, maybe even more, these polyps just grow, and then a mutation can occur that leads into a cancer. So whenever we do a colonoscopy, if we see polyps, we can remove those polyps, and that is the best way we can prevent some cancer from developing. Now, polyps can occur and they can recur, and depending on if we do a colonoscopy and remove a polyp, if we remove a polyp based on its size and its pathology, we then can determine when the next colonoscopy would be. So if there's polyps that are there, then another colonoscopy to prevent them from forming. Now, we don't know exactly why people develop polyps, but a lot of people do. In our literature, about 30% of people who undergo a colonoscopy will have some level of a polyp. Not all of them turn into cancer, though. Now, things that could potentially increase the risk of polyps include things like smoking. We do have some data now showing things like red meats, high fats can also lead to that. But even despite people's best efforts in diet, exercise, staying healthy, these polyps can occur just from genetics. So colonoscopy is just a great way of trying to prevent and being proactive as much as you can.
Dr. Court, you have your hand up. You
Yes, I
have a
did.
question?
I was gonna, the doctor answered my question partially. I was gonna ask him what type of foods may trigger the growth of a polyp.
Mhm.
So very good question and a very, very common one. And we don't have a lot of great data, but what we do have so far are things like red meats, or saturated fats can increase the risk of developing colon cancers. And part of that cancer progression is that things start as these polyps.
Mhm. Excellent, excellent.
So-
All righty. I have we're going to give you a break just for a minute because we have a question here that came in about prostate, and I think it's a very important question. Please share the next steps if my current prostate reading from my PSA is 4.2 from 3.95. I do ride my bike on a regular basis. What is your opinion on neutron versus other types of intervention? I know that this is a problem for African-American males, definitely prostate problems. And Dr. Court, can you just give us an indication of the number that he's describing? What is it, 4.2? Is that a big number? Is that a small number? Is it a number that he should be worried about? Where are we with this?
Well, yes, he should be because the number is greater than 4. Normal PSA should be between 0 to 4.0.
Mhm.
But what is also important is the rate of rise or doubling of the PSA. Say if, for example, the PSA a year ago was 1.5, and this year it's 3.2. Although 3.2 is below 4, that patient should be seen right away by a urologist to make sure they don't not have prostate cancer.
Mhm. Yeah.
So in other words, from 3.9 to 4.2, certainly you should see a urologist to determine whether or not, depending on what he feels, if you need to have a biopsy.
Mhm. Yeah.
Depends on your age also. I didn't get how old the patient is.
Mhm. Yeah, usually what age would you would say, and maybe in the 60s or 50s? What for a Black male would we be concerned?
Anything over the age 40, because we've
Mhm.
seen it with patients younger than 60 who have
Right.
developed prostate cancer, especially if it runs in the family.
Right, right. Mhm. Now, I would have to talk to a urologist about the neutron versus the types of intervention. But Kevin, do you have any experience with this?
Well, I think first you have to make the diagnosis.
Right.
So they need to get an exam and also a biopsy to see what, if it is indeed prostate cancer. There are other things that can cause an elevated PSA. You can have an infection, prostatitis, and other things that can cause an elevation. If he does have prostate cancer, then it depends. There's different options for treatment, from doing nothing and just observing to having a prostatectomy. So we'd have to get more information to see, one, if he does have prostate cancer, and two, the full extent and the stage of it, to determine if surgical therapy is warranted, radiation is warranted, or if he can take hormonal therapy.
Right, right. Yeah. Dr. Jordan Garrison, you have your hand up. You're on mute.
Good afternoon. And I think you guys covered the prostate issue.
Dr. Garrison, can you increase your volume just a little bit? Is it possible?
Okay, how is that? Is that better?
A little better, yes. Mhm.
Okay. I think that this prostate question was covered pretty well. I think people, any increases in your prostate PSA, you should seek out help with your urologist. I would like to return back to the whole colonoscopy issue if possible. I think it was well covered. And so I have a question, because I run into family members, colleagues, and friends who are doing all these things in their colon. Particularly, they go frequently for colon washouts. They do these juice diets. They do chelations. all this other pseudoscience that's out there. And I think by me saying that shows where I'm at with it. It's like, I think it's pseudoscience. But could you comment on people who feel the need to go and have these colon washouts, and then all of a sudden they don't eat meat, and, all these things that are out there for colon health?
So, Dr. Garrison, thank you for that question. That is a very important question, and it's one that I also I can talk a lot about. I could say when it comes to things like colon cleanses, right? Like particularly when people go in for these colon washouts and things of that nature. And I see a wide array of patients who, and by the time they come and see us, unfortunately, there are not a lot of gastroenterologists in the country. Sometimes getting in to see us, people try whatever they can with their symptoms. And I totally understand that. But what I do find is that, we really use our evidence to how we practice and make recommendations. And when it comes to things like colon cleanses and washouts, there's just not a lot of really good data out there. If anything, what I have noticed is harm. Harm because you're taking something and washing physically, you're washing out the good bacteria in your colon, right? So we also have a very delicate microbiome in our colon, where we have bacteria that live there, good bacteria that aid in digestion. They help in things like your immunity, your metabolism. We are finding that the microbiome plays a role in things like mental health. It just plays many roles within the body that we're uncovering now. And when we go in and wash out some of this good bacteria, then it creates more of an imbalance in that system that can create a problem where people could develop worsening constipation, diarrhea, abdominal pain, not digesting things the right way. So unfortunately, even though it sounds like a good idea to wash out things, it could create some harm. The other thing I do notice is sometimes the actual tube itself creates trauma. I had a patient once that had a perforation of the colon with it. So, and unfortunately, these things are not regulated. There's a lot of information out there. There's a lot of stuff on the net about this, but I don't see a lot of benefit with it. I do not recommend it.
One of the problems too, and this applies to a lot of alternative medicines, is, as you pointed out, it can cause harm. And that's one of the things we do have to pay attention to. Sometimes, patients come in and ask if I can take this or that. And some things that are harmless, it's, if it doesn't affect the therapy, it's okay, especially chemotherapy. But in cases where there is an interaction and it is harmful, then it definitely shouldn't be done. The other thing is, a lot of times patients will use it in place of things we know that are standard. So they'll use the cleanse in place of getting a colonoscopy or screening. And that's also important to make sure that they're not utilizing these alternative things in place of the standard therapy.
Of the standard test, yeah. Dr. Sprott, please.
Yeah, I part of my concern is the terminology that's being used. And when you talk about cleansing, you're talking about trying to clean something that's dirty, and there's nothing about the contents of the gut that are dirty or that need to be cleaned. The gut is something that's healthy, and the purpose primarily is to digest the food that we eat. And what food that we eat that doesn't get digested gets excreted. The same thing happens, when you talk about the kidney and its filtering of the blood, and it filters the urine. There's nothing about the urine that's dirty. And so you don't talk about that as being cleansed. And so there's a bit of marketing and advertising that goes along when they talk about cleansing your gut or doing a cleanse, because as was indicated, there's the bacteria that doesn't need to be cleansed. It needs to stay there to do what the function is. So we need to be careful about some of the terminology that's used to sell products, or to come away with the belief that because the gut eliminates feces, that there's something wrong or dirty about feces. It's just a natural byproduct of what all animals that digest food have to eliminate. And so I think the issue of the gut needing to get cleansed or to do a routine cleanse once a week or once a month or once everything else is sort of improper and misleading.
All right, thank you.
Okay, that's good.
Dr. Court, your hand.
Okay, I'd just like to piggyback on what was just discussed in terms of use of so-called medications to clean your bowels, but more so in terms of the use of so-called bush that many Caribbean people use to clean. How does Dr. Ali feels about use of so-called bush?
Sure. So I grew up every week or every couple of weeks, my mom coming with some senna, and I had to take some senna to clean me out. And it's very common in Caribbean homes that we do that. And but it's something that I don't recommend because your gut and our digestive system is a very delicate but a very advanced system that will take out and utilize what it needs and excrete what it doesn't need on its own. Now, sometimes when people suffer from an irritable bowel, where they may have constipation, they're straining to go to the bathroom, and this sometimes can also occur in children, right? Then we can use things that allow you to have more regular bowel movements to avoid issues like pain, bloating, increased gas. But in terms of that prophylactic clean out, I don't recommend it. And it was actually something that I've learned over the years and in medical school and with medical training, because growing up, it was commonplace for me to think, oh, this was a normal thing because this is what we did when, as a kid. I used to do it all the time.
But comment on the use of bush.
Oh, I specifically wouldn't recommend it, because even though those bush teas, they provide these the laxative effect, a lot of times it's the senna itself, like the senna leaf itself. There's also some byproducts in it that can pigment the colon. It can pigment the colon, and it's called a melanosis. So, and a lot of times these are advertised as natural tea supplements to help you go, but we don't know what it necessarily does, in the sense that why it does this, why it pigments the colon darker than it should, and what the long-term effects of that are. So my recommendation is, if people do need something to go, right, not using something like bush, but the safest thing is actually something like Miralax, polyethylene glycol, because it doesn't metabolize to your kidney or your liver. It just creates a little bit more water to come into your system to allow you to go. So yeah, my answer, sir, is I don't usually recommend the bush.
Mm-hmm. You're talking about pigment. What you mean by that is that it actually turns the bowel dark. Your colon and your small intestines dark. Does that hinder you from diagnosing different diseases because of the color?
Correct. It's an entity that we call melanosis coli, where there's just a pigmentation that occurs within the colon wall that's supposed to be a pink, kind of like the inner lining of your mouth, like that color, that where you can actually see the blood vessels. But there's something that deposits in the layer that prevents that. So when I see, a lot of times I detect this at the time of a colonoscopy, and sometimes I'm unable to see things like polyps or look for ulcers or maybe any other issue.
Mm-hmm. Mm-hmm. Excellent. Dr. Sprott, yes.
Yeah, you mentioned issues related to pediatrics. There are a lot of problems in pediatrics related to the gut, gastroenteritis and constipation. And one of the things that people have questions about is what's regular? What's a regular bowel movement, and what's a regular frequency of having bowel movements? Because that gets confusing if people think that there's a norm and then they aren't doing what's the norm.
So I agree that for some reason, a lot of folks think, and even I used to think at one point, well, one a day and you're fine, but everybody's clock is a little different. I meet patients sometimes that tell me they have a bowel movement once every 3 days or once every 4 days, and that's regular for them. And if you're not having issues with abdominal pain, bloating, gas, or any sort of symptoms related to that, that's okay. I have some patients that may have 2, maybe 3 bowel movements a day. And if that's regular for them, that's okay. For most, I would say a bowel movement at least once every, 1 to 2 or 1 to 3 days is okay. But if you're noticing things like abdominal gas, bloating, and you feel like you got to go and you're straining at that point, you may need something to help.
So in pediatrics, we start out with the babies. Normally breastfed babies very often have bowel movements every time they nurse, something called the gastrocolic reflex. But with breastfed babies, it's sort of the consistency of the stool is important. It's sort of like uncooked scrambled eggs, and that's sort of the stool. And then after maybe a month or so, they may stop having bowel movements altogether if they're exclusively breastfed, and they can go for days, sometimes a week, without having movement. Then they have a large movement, but it's that same consistency. And then it changes once you start to introduce solid foods. But what we stress is the issue is the consistency of the stool. People don't realize, but one of the things that the lower part of the gut does is it extracts water from the feces. And so if you think about water extraction, the more water that's extracted, the drier it gets, and the more difficult you might have passing a stool. So if you're passing a stool that's hard with the little round balls, that's dry, we consider that constipation. So what we want is a stool that's sort of a semi-solid or soft consistency that's easy to pass. And if you're having bowel movements that are easy to pass, then we don't call that constipation, even if you're only going once every 2 days or once every 3 days. But if you're going every 3 days and you're having difficulty passing it, usually it's the initial part of the stool that's the hardest, because that's had most of the water extracted from it. And after that, you can look at the stool itself. You see it's softer because there's gradually more and more water content. But it becomes important that you look at, are you straining? Is it hard? Because with some of the kids, if they have a hard stool that they pass, it's uncomfortable. And then they won't want to have a stool. And the urge to defecate or eliminate a stool is based upon that stretch at the rectum that says, oh, I have an urge to go, and you go. Well, if you have a hard or difficult stool for a child, even though they feel the urge, they may hold on to it, which makes it drier and harder. And you can get to this cycle that occurs that can be a prolonged issue with constipation, which may mean what you talked about before, using a stool softener. And the real key to that is for these kids that have this issue is to treat it for a long time. If they're going once a week and they have a hard stool, then every time they go once a week, that stool gets larger and stretched, and it becomes uncomfortable. And so you want to have them passing normal soft stools for at least several months, and then the tone of the rectum starts to come back. And it's that tone of the rectum that gives you the urge to defecate when the stool settles there.
Excellent. Dr. Garrison.
Once again, I'd like to revisit some stuff. And just as an example of how closely related our gastroenterologists have to work with surgeons to get an understanding of what's going on and how to treat these problems. You were talking about prevention of small bowel obstructions or obstructions in the GI tract. And we have to break it down into age groups. And, Dr. Sprott can talk about the pediatric problems, newborn problems, pyloric stenosis, and things like that, which can cause it. But then when you talk about young adults up to the age of 40, 50 years old, there are other things that cause small bowel obstructions, usually incarcerated hernias, twisting of the intestines, Meckel's diverticulum, things like that. Usually in a 50 to 60-year-old age group, we're talking about adhesions, which was alluded to before. Is there anything that we can do to prevent adhesions? No. They're scar tissue.
Doctor, what is an adhesion? Describe it.
As
So
I was explained before, it's like when the intestines have been manipulated from an outside source, you get scar tissue. And this scar tissue could look like simply as thin as saran wrap over the intestines. It could be thick like wax paper over the intestines. But what happens is the intestines will twist and the scar tissue prevents it from untwisting. And sometimes the treatment for that is simply put the bowel at rest. But if it goes on for an extended greater than 3 days, then usually some type of surgical intervention is necessary to get rid of that scar tissue and untwist. It was also mentioned by eating proper foods, decrease the amount of fat, increasing your fiber load can help the intestines get through that, those adhesions or those twists. But more than likely, adhesions, if they don't resolve spontaneously within 24 to 48 hours, usually requires a surgical intervention. Now, if you go into an older age group at age of 60 onwards, the first thing you have to think is about some type of cancer or tumor that's creating that problem. So depending on the age, will depend on the type of treatment or the diagnosis. But the walkaway has to be that whenever you have abdominal pain for longer than 24 hours, we have to find a reason for it. We just can't walk away and say, okay, it'll get better, take some laxatives or this. If it persists for more than 24 hours, that is something that a patient needs to come to the hospital and be evaluated by a trained healthcare professional.
excellent, excellent. Yeah. All righty. I'm going to tackle another question. Please touch on GERD. All right. Gastroesophageal reflux disease and diverticulosis. All right. I think we touched on diverticulitis and losis, but I'll let you handle it, Dr. Ali. Start off with that.
So, just again, to revisit that diverticulosis. So what happens is over time, you can develop these little pockets along the colon, right? The pressure system within the colon wall, it changes over time. And these pockets just develop as a process of aging, but sometimes as well, diet contributes as well to this. And these little pockets, they don't reverse, they're there, but over time, more can develop, and very rarely, not actually very rarely, it's not uncommon that sometimes stool can get caught up in these little pockets. And if that happens, it can create a localized infection or inflammation of that diverticula, which we call diverticulitis. Itis at the end is inflammation of some things, like appendicitis is inflammation of the appendix. Diverticulitis is inflammation of the diverticula. And typically how we would manage this is if these symptoms, people can present with things like abdominal pain or sometimes fevers, chills. And, as Dr. Garrison mentioned, if you're noticing that you're developing abdominal pain, you need to get evaluated. And if it's something that persists, you need to get evaluated by a healthcare professional very soon, immediately. And sometimes the way these are diagnosed is by imaging. We could do an exam, we could get some imaging, and we could see if one of these diverticula may be inflamed, and the treatments may be things like a combination of some IV fluids, rest, antibiotics, in severe cases, sometimes even surgery. Not all. A lot of times, though, we try the medical management first, particularly with the course of antibiotics, and that should do the trick. Now, how do you prevent future issues or problems from happening? Usually fiber, and fiber in the diet, like a high fiber diet, or if people aren't getting enough fiber in the diet, even a supplement like things like Metamucil, or soluble fiber like Citracel, Benefiber. This all helps to congeal the stool so things don't get caught up in those little pockets where it can create a problem. Now, reflux is different. And this is a situation where in your stomach, now when we eat something, food passes through your esophagus and into your stomach. And the purpose of the stomach is to take that food and it breaks things down into its components. So we have acid in our stomach, and it's designed to be there to break down food so it can be broken into things like carbohydrates, proteins, fats. And then from there, it gets into the small intestines where absorption occurs. So that's kind of what we call our absorptive powerhouse. Now, sometimes in the setting of reflux, that acid can spill over into the esophagus, and that can create a feeling of a burning sensation or discomfort in the upper part of the abdomen. People can develop things like nausea, or feel like they need to vomit, or even like a persistent feeling of something at the back of their throat, and that a lot of times could be related to reflux that can occur further up. Sometimes people could present with a cough after eating a meal, particularly. So these are some very common symptoms that can occur with reflux.
Yeah. You know, I come in contact with this very often as a pulmonologist because it's one of the reasons that we develop bronchitis. And also, I've had patients that have had such severe reflux that they actually scarred their lungs because of the acid. The stomach has a particular type of tissue that can handle the acid. The esophagus, which is the tube that leads to the stomach, as well as the back of the throat and the lungs, the airways of the lungs and the tissues of the lungs, that tissue cannot handle that acid from the stomach. It's a very potent acid that breaks our food down. But the thing of it is that what I've told my patients in the past that have had reflux and recurring bronchitis because of reflux, a lot of times it occurs because during sleeping hours, they're laying supine and their stomach is parallel to the back of their throat. And when that happens, it's easy for the acid, just a drop or two during the night, to drift up into the back of the throat, and they can either wake up coughing or in the morning wake up feeling as though they have a acidic taste in the back of their throat. And this over time develops bronchitis, but the recurrence of bronchitis is that's not good, number one. But what I tell my patients, and you can let me know if this is correct. Over the years, I've developed a kind of a system. Number one is to talk to your primary care doc or the GI doc. Number two is to maybe get some type of medication that can decrease the acid in your stomach. Number three is to get a wedge, one of those foam wedges that puts you at 30 degrees on your bed, such that your stomach is below your back of your throat, and gravity will hold the gastric juices in the stomach while you sleep. And those are some of the things that I tell my patient, and it seems to help. Now, what
Omar,
about
you mentioned supine. Could you explain the supine position?
supine position? Is when you're laying flat and your head and your feet are at the same level on the bed. What I like for the patients to be
On your back.
on your back, yeah, on your back. You're correct. I love, yeah, on your back. So what we try to do is we try to have our buttock area lower than the back of our throat, and that wedge at 30 degrees makes sure that your stomach is below the back of your throat, and that gravity holds that acid in the stomach during sleeping hours. All right. Anything? We'll let Dr. Ali. You'll add to that, but and Dr. Sprock, you'll be after that.
Okay.
So you're right, and remember, right, when we eat something, it goes down the esophagus into the stomach, and you've got a muscle there that keeps that barrier from the esophagus to the stomach, right? It's called the lower esophageal sphincter, and it's a muscle that usually stays nice and closed and tight. And when food gets through it, it relaxes to allow things to get through. But what can happen is if we eat a meal and say there's a lot of acid being produced, sometimes if it's a little more acid than there should be, and a lot of times it could be related to also diet, which we'll talk about, but that acid spills up over because there's a relaxation of that muscle itself, and that's what causes the reflux. So a lot of times people get this at night, right? They eat dinner, and then what do we do shortly after eating something? We go from the standing position to laying flat in bed. And that barrier, the acid that keeps, the gravity keeps acid down, right? But now that we've changed things where we're laying on our side or we're laying on our back, that acid becomes more level playing field with that sphincter, and things can also spill over. And the other part of it is the amount that we eat and what we're eating. So a lot of times what most people will end up doing is our largest meals of the day tend to be dinner time. And most of the day we're up, we're working, we're moving around, maybe not eating as much. But then for many, dinner is our largest meal of the day, and it can tend to be things like certain meats, fats that recreate a little bit more acid because it needs that for digestion. And that's why people can suffer from nighttime symptoms.
Mm.
And the foods that can trigger this include a lot of things like fats or red meat, spicy foods, foods that can promote more acidity in general. And not that that's bad for you, but it can create a problem with more acid. So I usually recommend avoiding the trigger foods, chocolates, red meats, spicy foods, fried foods. I also recommend eating, sometimes if we can eat smaller meals more frequently through the day, it doesn't overload the system of the stomach to create a bolus of acid to help in digesting things at one time.
Excellent. Dr. Sprott.
Yeah, reflux is something that is not sort of active, if you will. It's not vomiting. And all babies will have reflux. That means that lower esophageal sphincter opens up. And if the baby has air at that junction, when it opens up, the baby will have a burp that just is air. And that's why we like to ask the mothers or the father to position the baby sort of with on their chest, leaning back, which puts the air that's in the stomach near that junction so that they won't have a wet burp. Because if there's air and milk there, and then the milk will come up. And that's why you'll see the baby might have milk come up through the mouth or through the nose. The good thing about babies, though, is that the acid that's in their stomach is balanced by the milk that they're drinking. So, and they're nursing, or they're having milk every 2 to 3 hours, which means that when they're having this reflux, it's almost always with milk, and the pH of that milk and the acid is going to be balanced. And remember, and this is part of what I wanted to talk to Dr. Ali about, is in terms of digestion. But remember that as long as the baby is having reflux, it almost always goes away with time. And so you don't really need to do that. And so you shouldn't have anybody on any kind of medication to deal with reflux in a baby, because it's not something that's going to persist. It'll go away with time. But I did want to ask a question about the other part of the digestion that occurs via the pancreas, because the pancreatic enzymes are something that if they get turned loose in the gut, when we talk about adhesions, usually being the result of abdominal surgery. But the pancreas, if something happens to the pancreas and it releases pancreatic enzymes into the abdominal cavity, it can be a nightmare. Could you spend a little bit talking about the pancreas and one of the things that a lot of people are experiencing, this issue of pancreatic cancer, and maybe our cancer specialist can talk about that. But could you talk a bit about the pancreas and pancreatitis?
Sure. So the pancreas is an organ that is very important in how food is digested, right? It releases the enzymes that help in breaking down fats, certain fats. And what it does is, as we eat, the pancreas will release these enzymes in the small intestines, and that can help in breaking down some of these larger foods, and particularly the fats. Now, in the setting of pancreatitis is inflammation of the pancreas. And how people can develop pancreatitis, there's a couple of reasons. There's a few different reasons why. The two most common causes that we see here in the US are related to gallstones. Where a gallstone may come out of the gallbladder, and it shares a ductal pathway from the gallbladder out, where things empty from the gallbladder into the small intestines. And it shares a common pathway with the pancreatic duct as well. And if there's a stone that may come out of the gallbladder, and gallstones can be seen in up to 25 to 30% of people naturally. It doesn't create a problem for everybody, but sometimes if this stone gets stuck in the ductal system, then as the pancreas is releasing these enzymes, and if it backfires because it's blocked by that stone in that duct, then it can cause pancreatitis. The other common cause of pancreatitis is alcohol. Chronic alcohol use can trigger pancreatitis as well, and inflammation of the pancreas. Now, pancreatitis is very painful. it's one of these organs. It's very delicate, and the enzymes that break down the certain things that are necessary for digestion, as you mentioned, Dr. Sprott, it's caustic. It can create, it can cause a sequence of events that creates a lot of pain, destruction. It can cause a lot of damage as well. So when that happens, what usually it requires somebody to get admitted into the hospital, lots of IV fluids and rest, allowing your body to heal on its own. Now, pancreatitis is different than pancreatic cancer. And you know, maybe Dr. Clark, you could probably talk a little bit more of that about pancreatic cancer as an oncologic surgeon. But that's a little bit about how pancreatitis can occur. Other things that are medications rarely could do it. Sometimes we have no rhyme or reason of why somebody may develop it, but they do. Or there could be some other type of a blockage in the ductal system that leads to that pancreatitis.
Excellent, excellent. We have Dr. Garrison. Your hand's been up for a while. Thanks for being patient.
Oh, of course. Yeah, one other cause that gets overlooked in pancreatitis is lipids. Hyperlipidemia, hypertriglyceridemia is the third leading cause in pancreatitis. So people who have a high fat diet can have this problem as well. You know, I don't know a lot, but one thing I might know about is a little bit about reflux disease, and having operated on that area for a greater portion of my career. The lower esophageal sphincter is actually not a muscle. It is just the esophagus. And what causes the closure of the lower esophageal sphincter is the last 2 to 3 centimeters of the esophagus before it joins the stomach. It's inside the abdominal cavity, and it doesn't ride in the thoracic cavity. It is the pressure difference between the thoracic cavity and the abdominal cavity that causes it to be competent. When we lose that pressure differential, we get relaxation of that lower esophageal sphincter, and therefore we get the reflux. What causes that relaxation or causes that loss of that pressure differential is something called the hiatal hernia. And it could be a sliding hiatal hernia, which means that the 2 to 3 centimeters goes up into the diaphragm. It could be paraesophageal, which means there's a hernia in the diaphragm. So those are the causes. Things like chocolate, things like alcohol, what they do is cause that lower esophageal sphincter to relax. It's from a surgical standpoint, it's not necessarily the acid content or the degree of acid production, but it's the loss of that pressure differential, which causes the acid to reflux up into the stomach, up into the esophagus. And as you alluded to, it can cause things like chronic asthma. It can cause like a chronic cough. And to put the wedge under the head at night is very, very helpful. Sometimes we just say put 2 wooden blocks under the headboard and to elevate the whole bed up instead of the wedge. But one of the questions that I ask the patient, they might not inadvertently know that is they're just treating themselves, where I'll ask, how many pillows do you sleep with at night? And that's a quick way to get to, are you having reflux and things like that. So the surgical management of reflux, again, is, yes, you want to control the acid producing, you want to control the medications or the foods that cause the relaxation, but the surgical treatment is to repair that dynamic, to get the lower esophageal into the abdominal cavity. And people will say that they've had hiatal hernia repairs. It's an interesting phenomenon that I've found that, the gastroenterologist will do an endoscopy and they'll retroflex the scope to see if there's a hiatal hernia. But what we have found is that 25 to 30% of the time when it says that there is no hiatal hernia, on expiration there is, and 20 to 30% of the time when they say there is a hiatal hernia, on exploration there isn't. So but that's the management of what we're trying to accomplish with the reflux. So laying on your stomach at times can cause increased pressure in your belly, which can give rise to reflux. And I think that's one of the reasons Dr. Sprott was talking about the positioning of the baby on the chest, So you can decrease that pressure, also laying on the side as opposed to laying on the stomach. So there's a lot of things we can do to help out with reflux. But the other problem is if we allow reflux to go unintended for extended period of time, or even people who are on anti-reflux medications, you could develop something called Barrett's esophagus, which is a precursor to esophageal cancer. So if you have reflux, it's necessary for you to stay in close contact with the gastroenterologist and repeat endoscopies. And if you get this thing called Barrett's esophagus, close monitoring, because it eventually can turn into a esophageal cancer.
Excellent.
Are you going to be offering courses to the gastroenterologists and endoscopies, Dr. Garrison?
So, you know, you're right. Sometimes we don't see the hiatal hernia, right? And sometimes we do. And it's because the organ is constantly moving. It's contracting up and down, right? And the junction itself that we look at, you're right. When you retroflex, that's where you could see sometimes that hernia. Sometimes we don't see it and it's very small. We may say, oh, you have a small hiatal hernia that's there. Now, does that usually mean, though, that you need surgery? Usually not. Now, a lot of times we try, the first measures that we do are things like dietary changes. But if that doesn't work, using antacid therapy is okay. Antacids were one of the most widely prescribed medications on the planet. This is a very common condition. So, and we have some really good medications that are out there to treat reflux if necessary. And you're right as well about if we don't treat the reflux, it could lead to problems down the road. 10% of people who have reflux can develop Barrett's esophagus, or over time, reflux can lead to damage, and that could lead to scar tissue, and people could develop strictures or rings, which are blockages at that junction where the esophagus meets the stomach, that lower esophageal sphincter. There could be a blockage there, and it may need, when you eat, food may even get stuck. And that could be a later complication of reflux. So medications, though, and that's another big topic that we could talk about, can be very effective if necessary.
Excellent, excellent. You know what we're going to do right now? We are at half point, and I'd like to just go through our half point introductions and stuff like that. When we come back, I'd love to go through some questions. We have quite a few questions. I'll put it this way, a lot of questions that we're going to have to tackle. So let's do this. Let me get my halftime act together here. Well, I'd like to thank OBHealthy for allowing us to bring this webinar to you. They sponsor us so that we can use their platform, and thank you, thank you, thank you. If you want to see our past webinars, please go to OBHealthy's website and just tap on the YouTube channel. All of our past webinars are there. Education is so invaluable as far as our medical care is concerned. Understand that we are here every second Saturday at 1 o'clock. As I stated before, OBHealthy's website, go on, hit the physicians tab and come right in, ask your medical question, okay? Number one, number two, and number three, as far as being important, please do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you from a medical standpoint, all righty? And from here, I'd like to have each of our physicians reintroduce themselves. Dr. Ali, can you start us off in reintroducing, please?
Yes, my name is Mazhar Ali. I'm a gastroenterologist at Scripps Clinic in San Diego.
Oh, thank you. Dr. Court, please.
James Court, specialty is internal medicine. Practice is located in East Orange, New Jersey.
All righty. And Dr. James Garrison, Jordan Garrison.
My cousin. Jordan Garrison, I am board certified general bariatric and vascular surgery, presently practicing in Hackensack, New Jersey, specialized disorders of the venous system.
All right, thank you very much. Dr. Clark.
Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist. I work at the Newark Beth Israel.
All right, excellent. Dr. Aluya, welcome back, brother.
Thank you. Sorry I came in late. but I have to be here anyways. This is really important to me as well. So Nelson Aluya, Medicine Pediatrics, Chief Medical Officer of the Newark Community Health Centers here in Newark, New Jersey.
Excellent, excellent. Dr. Kendall Sprock.
Yeah, I'm Kendall Spraja, board certified pediatrician, specialized in critical care pediatrics and general pediatrics.
Excellent. And Dr. Patrick Anderson. Hello, Pat. You're still on mute. Oh.
I'm still here, didn't leave.
All righty.
Hi, everyone. I'm Patrick Anderson, board certified gynecologic oncologist. I work out of Newark Bethesda Medical Center in Newark.
Excellent, excellent. And I'm Dr. Omar Bey, pulmonary critical care and subspecialty in nutrition, and trying to be a webinar host. Trying my best. What we have here is some questions. Is taking Metamucil daily helpful, or does it or does it mask other digestive problems?
So I think that taking fiber, any fiber, is helpful for a few different reasons. One, it helps to promote more regular bowel movements because stool can congeal, allowing for that. But also it enhances the microbiome. It helps in flourishing, particularly bacterial strains that release butyrate, which are very beneficial to colonic health. It actually can also help in things like cancer prevention, helping with inflammation as well. So it works in a very indirect way. There's two types of fiber out there. There's something called soluble fiber and insoluble fiber. Metamucil is insoluble fiber. It's not a bad thing, but some people can get bloated, gassy, a little bit more distended with it because it's a little bit harder to digest. Soluble fiber are things like psyllium, citrusel, benefiber. It works a little differently, where it doesn't create as much issues with gas or distension for folks. So depending, if you don't suffer from gas or bloating, then Metamucil is just as fine. It doesn't mask anything. I think it's overall, I call it the colon's best friend.
Mm-hmm. Excellent, excellent. Soluble, insoluble, big words. What do you mean by that? One is absorbed and the other one isn't, or what's going on?
It's just, it takes a little bit more out of absorption. They're harder fibers. Thinking about, like, for example, certain foods like celery or the stalk of a broccoli. It's a little bit of a harder fibrous product that your body takes a little bit more out of digestion. As a result of that, it can cause more gas, bloat production. And the reason why is because by the time it finishes digestion, it may not be completely digested, and the bacteria in our gut are going to try to help digest that, but it causes more fermentation. Mm-hmm. Not that it's a bad thing by any means, but for people who suffer from gas and bloat, some of the insoluble fibers can create more of a problem.
Right. Excellent, excellent. Next question: what role does B12 play in digestive health, as far as B12 is concerned? But yeah, I know that you deal with B12. Well, I don't know if you deal with B12, but Dr. Court, I know as far as B12 is concerned, as far as the blood system is how do we relate that? And can you answer some of these questions about B12 and digestive health? Does it help with digestion and inhibit digestion? Where are we with that? So between the two of you.
I don't know that it helps with digestion. It's a test that we use to test one form of anemia, vitamin B12 or folic acid. Anemia due to those two things. But in terms of how it helps with digestion, I cannot think of a way. I don't know if Dr. Ali can or anyone else.
So B12 is absorbed in the small intestines. That's where in the stomach, actually, certain proteins attached to B12 that allow for the delivery of the vitamin into the system through the small intestine. So that's where the absorption occurs. People who may suffer from B12 include people who may have part of a bowel resection where that part of the small intestines may not be there, or there may be inflammation. A lot of times I may see this in the setting of somebody who may have something called Crohn's disease. Sometimes there is a condition in the stomach called a type of autoimmune based condition called pernicious anemia. This sometimes can cause an issue where B12 can also not get absorbed properly. So there are some GI conditions that can lead to B12 deficiency. So sometimes you want to consider, if you're not able to figure out why you may have a B12 deficiency, there could be a GI source for it.
Mm-hmm. Dr. Garrison, I know that you're jumping in here because of bariatric surgery. Tell me about it.
Oh, how'd you know that?
Uh,
Yeah, there are conditions that we create that can cause B12, a pseudo B12 deficiency. And Dr. Ali already alluded to the fact that there's protein in the stomach called intrinsic factor that bonds with B12 that helps absorption. If we do a gastric bypass on a patient, we've excluded that area of the stomach that produces that protein. So therefore, the B12 doesn't bind, the B12 doesn't get absorbed. So that's one of the things that we create. We advocate for the patients to take B12. And on the other end of the treatment spectrum, when a patient comes in and they've had persistent vomiting, because again, you vomit out that intrinsic factor, one of the first things that we do is give them thiamine, 100 milligrams of thiamine for at least 3 days in a row to counteract that deficiency.
all righty. Let me do this. Dr. Atherley just came in. Dr. Atherley, please, thank you, number one, for joining us. And can you introduce yourself, please?
Good afternoon. My name is Trevor Atherley. I hope you can you hear me well?
Yes.
Very
good. I'm a cardiologist and interventional cardiologist, primarily based at Newark Beth Israel Medical Center. I'm always pleased to be a part of the group. I'm sorry about my tardiness. I may only be with you for a short period of time because of something else that cropped up on my schedule, but I'm willing to listen and to be a part of you for a brief moment.
All right, thank you, thank you. The thing of it is that we have so many questions here. Now, Dr. Ali, I'm going to have to ask you. I know you put slides together, and we can bring those slides up and sort of go through those, or we can keep going through some questions.
I love the questions here.
All right, yeah, that's what I hoped you were going to say.
I think that we brought up some great discussion points, and yeah, we can keep this going. All
righty, sounds good, sounds good. All righty, the next question. I had constipation for over 30 years caused by a radical prolapse. Is it important to change my diet? What foods should I stay away from? And do I have irritable bowel syndrome?
They probably mean rectal
Omar
prolapse.
means a rectal.
He said rectal prolapse.
Was it rectal? Okay,
Rectal prolapse.
I'm sorry. Go ahead. As I said, I'm trying to be a host.
So, constipation, severe constipation that can lead to a rectal prolapse tells me there's definitely a problem here that needs to be further investigated, right? I'm not sure of this person's age, but I would obviously want to consider things like a colonoscopy, especially in severe constipation, taking a look, make sure there's no other reason why there could be a problem there. Irritable bowel is a possibility, but again, you'd want to make sure you do a workup first for this. So things like colonoscopy, maybe checking some blood work, checking a thyroid level. These are important pieces that we need to do just to get a broader picture of what's going on. In terms of if this is an irritable bowel, it might be. If we see that we don't have any other causes or explanations for this, then it certainly can be. And in that scenario, I would consider a stool something there are medications that we can use to help people to have a bowel movement. Usually my first go-to is something like Miralax, because it brings more water into the colon. It's something that's very safe. You could take it once a day. You could take it 2 times a day. You can cut the dose. There's lots of different ways you can use it, and it's a safe option. But if that doesn't work, we also recommend fiber. And then we have FDA-approved medications to treat chronic constipation, irritable bowel, constipation predominant irritable bowel. Things like there's medications out there called Amitiza, Linzess. So we do have medications, but you would want to see your doctor and talk about that further.
Omar, if I might add, it's important that if this the question is coming from a woman, that there is a good gynecologic evaluation, because depending on age, parity, meaning the number of children, the mode of delivery trauma, there may be associated pelvic floor injury with associated vaginal or uterine prolapse combined with the rectal prolapse that can cause constipation. So that's an important factor as well.
Excellent, excellent. Dr. Garrison, please.
Yeah, let's not put the cart before the horse here. If somebody comes in with constipation, then with chronic constipation, the most important thing to do and the easiest thing to do is a rectal exam. Common causes of constipation could be hemorrhoids, common causes, and in older age groups, a tumor. So we have this easy screening exam called the stool guaiac. And I think that is very, very important for us to do. The other things might be all of a sudden the new appearance of a hernia. It's like hernias we know have been there since birth. Or why now is it coming out? Because it could be the constipation, or the constipation could be caused by a rectal or a colonic tumor. So rectal exam, guaiacs are, I think, the first line that we should go to when somebody has constipation.
I agree. I want to also add, if of the screening age, making sure colon cancer screening is up to date as well, at 45 for men and women.
Excellent, excellent.
Omar, can I just want to jump in here. One of the things that we advertised for this seminar was the discussion of ulcerative colitis and Crohn's disease. It seems like, we got tons of stuff to talk about on GI habits and basic GI stuff, but I'd like to hear Dr. Ali go into some things about ulcerative colitis, Crohn's disease, and even steroid management and surgical indications, if possible.
All right, then. Let me do this. Give me a few more minutes with we have so many questions though, Jordan. I just want to say, but we can tackle that. Well, let's say the last 20 minutes, maybe we'll end up with that, Dr. Ali.
Sure.
That's good. And just let us know if you want us to pull your slides up, or you can just talk about it. Let's keep going. Are there any natural or organic things that can be done to speed up the healing of shingles? Shingles is interesting. Dr. Court, you're still here with us?
Yes, I am.
All righty. Can you handle this
No.
one for us?
I don't know of anything that can do it because it's a recurrence of chickenpox, or recrudescence of chickenpox, and it's very, very painful. And except for managing the patient with pain medication, there is no other treatment that I know of that you can give them. You might try some of the medications to treat the herpes, yes, herpes virus. Yes.
Yeah.
That's
And
about all I know.
What about the shingles vaccine? Since we're talking about that, do you recommend it, for elderly?
It's been touted by all the insurance companies that you should have it, and this is part of their protocol that they want us to do. So yes, I do recommend.
Excellent, excellent. Is taking Colace daily harmful? Dr. Ali?
No, if Colace works, that's okay. If Colace doesn't work, then again, something like Miralax might be a better alternative, but it's not harmful.
Okay, so there's a good question. It says, what color is poop supposed to be?
So that's actually a very common question that I'm asked as well. And we always think, well, we need this nice brown form stool. And a lot of times your color is based on what you're eating, right? So it could be green, it could be yellow, different shades of brown, it could be dark. But the one thing that I do get concerned about is if there's blood or red color. And the other is a setting of digested blood, which can present with dark black types looking stools, like what we call tarry looking stools. It looks like tar. Those are the two scenarios where I would be more concerned that you do need to contact your doctor and get further evaluated.
Yeah, but also, if I might add,
is iron.
Hold on. Who is that? Patrick?
Yes,
Patrick,
I was going to
first,
say.
then Dr. Sprott.
Yeah, I was going to say, and I think it leads into what Dr. Sprott was going to say about iron. the color of the stool sometimes, as Dr. Ali alluded to, reflects what you eat. I know I've had panic moments where I had a nice bowl of beaten butter, and 2 days later, I'm panicking, calling Dr. Ali. Listen, I think I need a colonoscopy because I have an episode of bright red blood per rectum. So that speaks to recognizing a symptom that requires on a consultation with your internist or your gastroenterologist is bright red blood per rectum. And sometimes things like beets, colored condiments, I say condiments, maybe spices such as turmeric, can give you that color that can set off a panic.
Mm-hmm. Dr. Sprott.
Yeah, the other thing is that you need to remember that 97% of iron that you take is not absorbed and remains in the gut and turns the stool dark or black. And so people that are taking iron for anemia, the absorption goes up a little bit, but it doesn't go up to more than maybe about 20% of the iron you get gets absorbed in order to replace the iron loss through blood loss. So 80% is going to remain in the gut. So if you're taking an iron supplement, it's going to turn your stool dark.
Also make you constipated.
Yeah.
Not so much constipation because it's not enough to make you constipated. That's a pediatric issue.
Yeah.
To add to that, Pepto-Bismol or bismuth is the active ingredient in Pepto-Bismol. It could do a similar thing to make your stools dark.
Yeah.
One other thing, we have to go to the opposite end. If your stools turn acholic or they start looking clay-like, is indicative of gallbladder disease or some type of pancreatic problem.
Mm-hmm. Yes, definitely. Next question. Is it okay to have bowel movements after each meal?
Yeah, sometimes that can happen. You can have in children, it's common, or Dr. Sprott mentioned about a gastrocolic reflex, right? You eat something and there's contraction happening, there's peristalsis happening, and your bowels are activated. So sometimes people may have the urge to have a bowel movement. Now, sometimes if you're having issues where you eat something and you got to run to the bathroom, right, where there's diarrhea, urgency, that may be a separate issue. But if you're eating something and you shortly thereafter need to have you're having a formed regular bowel movement, that's not uncommon, that's okay. But sometimes if you've got that urgency within minutes of eating or within 30 minutes of eating, you got to run to the bathroom, it might be a different issue altogether.
Okay. All right. Excellent.
If I may add to that.
Go ahead.
So there's what they call intestinal hurry. And that's, again, is an autonomic complication of diabetes. When the diabetes begins to really affect the nerves. And it may not actually occur when you're full-blown diabetic. It might actually occur in the stage where you're pre-diabetic, because the affectation of nerves or those small vessels that supply the nerves actually occur anytime, but predominantly when somebody's diabetic and uncontrolled. So it can occur. I know I did say the word autonomic because there are two pathways for nerve control, how you control the nerves in your body. The sympathetic and the parasympathetic, and then there's the autonomic and the other one, where you can actually control your muscles and the arms and everything else you do. Now, the autonomic ones are the ones that control, your heartbeats, things that you don't really control, that work automatically. Your GI movement, response to hunger, response to your heartbeat, all of those things are autonomic. And they're outside of your control. Even sweating and response to the weather and all that, those are autonomic. And diabetes can affect those, especially those who are uncontrolled, and that can affect the GI tract as well.
Yeah, excellent. Dr. Sprott.
Dr. Ali, you talked about rushing to the bathroom. There's something called microscopic colitis. Could you talk about that? That can be, it's not so common, but it's horrible disease.
It is, and it's actually it could potentially, it's argued by some to be in the realm of what we call the inflammatory bowel diseases like Crohn's, ulcerative colitis. Microscopic colitis may be kind of that third entity. And what that is it's a condition where you've got chronic loose stools or chronic diarrhea, urgency, multiple bowel movements a day, and the workup, meaning labs look okay, there's no infection in the stool. Even when we go in and look with a colonoscopy, there's no inflammation where we see ulcers or the lining looks healthy. But when we take a bite of piece of tissue and we look at it under a microscope, there is an increased amount of immune cells that is at the layer of the lining that prevents absorption. And that lining, it could be filled with what we call collagen, which is a type of substrate that's released that prevents the absorption of things from happening, or it could be what we call lymphocytes, which is a type of white blood cell, and it's just a thicker layer that prevents the absorption of things, and that causes diarrhea, urgency. The way it's treated is with steroids. There is a steroid that we can give people, and that can treat this. It's also a relapsing and remitting condition, meaning that it could flare up for people and then it can go dormant again. And it could do this in people, relapse and remitting courses.
Okay, since you started, Dr. Ali, why don't you run with Crohn's disease and ulcerative colitis or the inflammatory bowel disease? Why don't we start that now and then we'll finish up some questions.
Sure, maybe I could put up, we could put up some slides here,
okay.
and we can at least, I've got some nice visuals for folks to see.
Okay. Hold on for a second. We're going to get that together for you. All right.
Sure. So just to start, right? So Crohn's disease and ulcerative colitis, these are two terms that we use, but really the umbrella term that we use is called inflammatory bowel disease, right? IBD. And within that is Crohn's, ulcerative colitis, and the third that some argue is the microscopic colitis as well. Now, these are autoimmune diseases of the GI system, meaning that your immune system is recognizing your digestive tract as a foreign invader and it's attacking it to a certain degree. And it's not something that you caused, it's just the autoimmune nature of what happens. Other autoimmune diseases are things like lupus, or psoriasis is autoimmune disease of the skin. The autoimmune disease of the joints is rheumatoid arthritis. So very similar, this is the autoimmune disease of the GI system. Omar, if we could go down on the slides, or I don't think I have control of this, no.
Oh, you don't. Just tell us which slide you want. And also, can you explain what autoimmune is?
Sure. So an autoimmune disease is when your immune system is recognizing a certain organ as a foreign invader. It's thinking your immune system is designed to control infections, to regulate things. And if it sees an infection, it helps to clear it, right? Like when you get a cold, our immune system kicks in to clear that cold. Well, unfortunately, in autoimmune diseases, the organ itself, even though there's nothing wrong with that particular organ, your immune system is recognizing that organ, particularly in ulcerative colitis, for example. Your immune system is recognizing the colon as there's something wrong there. There's a persistent infection or there's something not right, and it's foreign to them. So it activates, your body activates cells that is then going to that part of the organ and attacking it and creating inflammation from your own immune system.
Excuse me, Dr. Ali. Omar, can you hit the slideshow button at the bottom of the toolbar to expand the slide so we can see it a little bit bigger?
Oh, righty.
I think it's the next one. No, the next one. Next one to the opposite direction. There you go.
There you go. Great.
Getting better.
So I mentioned about this being the autoimmune disease. Now, it occurs in all races, all ages, men and women. We used to think that this would affect certain races and it would affect certain people at certain ages as well. But I can tell you that I see everybody get this. Children get this. I have a pediatric gastroenterology colleague who treats children at age as early as 6, 7 years old with these conditions. And but where we commonly see it not always, but commonly we see it in kind of the early adult stages of life, so late teens, early 20s, and we can also see it happen later in life, in late 60s, 70s as well, but I diagnose it at all spectrums. We also used to think that it was a condition that would affect primarily Caucasians. That's not the case. It affects all races. Actually, there was a recent study that came out of Canada where Canada has a healthcare system. It's a more of a universal healthcare system. So they're able to really trend things like epidemiologic-based studies. And we see that the highest risk of people who develop IBD now are children of immigrants from Asian countries, South Asian countries. And we don't know exactly why. We implicate it could be related to the diet, the microbiome, but these are kids who are born in, their parents immigrated to Canada, they're born in Canada, and then they get the disease. So it's very interesting. And we think there are a couple of factors that lead into why and how somebody could get the inflammatory bowel diseases. But we do know it's a combination of genetic factors, the environment, diet, and these things are kind of what cause it. Here in the US, we've got more than 1.6 million people who have IBD. 70,000 new cases are diagnosed, probably more each year. And it causes a significant amount of hospitalization costs, frequent visits. This is unfortunately a condition that's lifelong. We don't have a cure for these conditions, but people could live normal, healthy lives with the appropriate management. Can we go to the next slide, please? So, you know, just a quick thing here to show that we used to think this was something that would affect the Western world, United States, Canada, North America, but we're seeing this occur now globally. And, you know, places like even the Caribbean, Guyana, for example, you know, we don't see numbers come in through studies, but people do have it. We've seen patients there who suffer from these conditions. So it can occur anywhere. And I think that we're starting to see more of it now than before because people have, you know, are slowly getting better access to healthcare. Globalization, diet, I think is also playing a strong role in this.
Quick question, Major. You know, one of the things that's always been a little confusing, you'll probably get to it. Are we talking, what disease process are we talking about? It's a term that includes a lot of different things. Making the diagnosis sometimes is always a little bit, or can be difficult, especially histologically. Are you dealing with classic ulcerative colitis or Crohn's, or is it a mix?
Sure.
Or is it something else?
If you go to my next slide, I have a picture. Here we go. So Crohn's, so let's go through this a little bit more in detail, right? So Crohn's disease is an autoimmune condition very similar to ulcerative colitis. The difference is how it presents in its location. Crohn's disease can cause inflammation in your small intestines, anywhere in the GI tract. It can occur in the esophagus, the stomach, the small intestines, or the colon. The inflammation can be what we call transmural. That means that the inflammation can be so severe that it could penetrate the entire lining of the GI tract itself. And it can cause inflammation in things like ulcers, bleeding, but over time, it can also even cause issues where that inflammation gets so severe, things could burrow into other parts of the body. Like, for example, part of the bowel can adhere to another part of the bowel and you can create a fistula or a connection or a hole there, right? That's called a fistula. You could develop fistulas to the bladder. You could develop fistulas to the vagina, to this out to the skin. Very, very debilitating condition here. You could also, due to a lot of inflammation, you could develop strictures where there's narrowings in the bowel, and that could lead to a bowel obstruction, requiring a surgery potentially. So Crohn's disease can be, for some people, much more severe if it's in its presentation. Now, the tricky part about Crohn's is not everybody has the same kind of Crohn's disease. Some people may have a very mild form of this. It only affects one part of your bowel, right? The most common place that we see Crohn's disease involved is the small intestine, particularly the end of your small intestine, a place called your terminal ileum. And the other, and then part of the colon as well. Other places, though, it can occur. And in a third of people who have Crohn's disease, they can develop what we call perianal fistulas, where people can develop really bad, debilitating abscesses or infections in the perianal area, the exit point, where the anus comes out. And you can also develop little connections or fistulas in that area where people can develop drainage. So that's what Crohn's, that's how Crohn's can present. Variable for everybody, and it can be a little complicated. Now, in ulcerative colitis, this is different in the sense that this involves the colon only. The inflammation is involving just the lining, the internal lining of the colon wall. And there's a few different kinds of ulcerative colitis. People can develop inflammation just in the rectum alone, or the bottom part of your colon, okay? That's called ulcerative proctitis. Some people could develop inflammation on the left side of their colon, which is what we see here in this picture. And then others can develop what we call pan-ulcerative colitis, where it can involve the entire colon itself, the entire colon lining, but not involving the small intestines, the stomach, or the esophagus. So it only is isolated to the colon. Okay, next slide. So the way we diagnose is, so Patrick, you mentioned this, right? Diagnosis is tricky. And it's a combination of things like your labs. Usually we diagnose this by colonoscopy and or imaging, depending if it's Crohn's or ulcerative colitis. But colonoscopy is one of the mainstays which we diagnose. Now, a picture here on your left is what a normal, healthy colon looks like. It's got a nice kind of pink color to it. You could see the blood vessels, like at least right underneath that lining. This is, again, what a healthy colon looks like. Now, on the top right-hand side is what ulcerative colitis or Crohn's colitis could look like. And they could look very similar. There's not a lot of distinction between ulcerative colitis and Crohn's, except when people develop strictures or narrowings, which we'll talk about in just a second. But the colon on the top right here, these are pictures of ulcers that are lining the colon. If you notice, you can't really see the blood vessels as well as you could see it on the left side. Now, that bottom picture is a stricture. And a stricture is when a lot of inflammation leads to scar tissue developing and inflammatory cells get into a place, and it causes swelling. And that swelling makes that hole, that lumen or that tube narrowed. And that's called a colonic or a bowel stricture. And it could present like an obstruction for some people, where they could develop pain, or they may need to be hospitalized for a bowel obstruction. But that's what that looks like. Now, particularly, we see strictures in the setting of Crohn's disease and not necessarily in ulcerative colitis. Sometimes you could rarely see that in ulcerative colitis, but ulcerative colitis, again, is more of a superficial lining of inflammation and ulceration. Next slide. Does anybody have any questions so far?
Yes, I have a question which you may answer perhaps on an upcoming slide. But in view of the diffuse nature of the underlying autoimmune process, what other organ systems, and I think you just pulled up the slide as I was asking, what other organ systems may be involved in these diseases, and which the Crohn's disease or the ulcerative disease may be more associated with generalized other systemic diseases, that is, disease of other parts and other systems of the body?
So very good question. And, because this is an autoimmune condition, right? Unfortunately, there's overlap, and because there may be some people, it's not uncommon to see two autoimmune conditions or other things that are involved. Excuse me. So we have in up to a half of patients who have either Crohn's disease or ulcerative colitis, they can develop what we call extra-intestinal manifestations. And meaning symptoms or problems developing outside of the digestive system. And that could be things like skin rashes, like a psoriasis. It's very common to see people who may have Crohn's disease or ulcerative colitis have skin rashes. And there's a particular one, an autoimmune condition called psoriasis. The other are joint pains, right? People could develop joint pains in the hands, in the elbows, in the knees. The knees are the most common. Actually, up to a third of patients who have Crohn's and ulcerative colitis can have joint pains. It's the most common extraintestinal manifestation. People could develop sores in the mouth. And sometimes that can correlate with increased inflammation that's also seen, or worsening disease activity, where people could develop more like canker sores in the mouth. People could develop more kidney stones, gallstones, or hepatitis as well. So there are, unfortunately, things that can also occur outside of the GI system, but they're all correlated and related. So now, a third of people with Crohn's disease can develop perianal fistulas. And this is a very debilitating thing where right at the exit point of the anal canal, little channels contract out into the skin, and it can lead to drainage. So people may notice that there's an increased amount of drainage occurring, like a bloody drainage, or we call a kind of a serosanguinous drainage, liquid drainage, if you will. This can increase the risk of abscess or an infection down below. And people who may suffer from a recurrence of this, and I meet people sometimes who suffer for this for years. The issue is that people don't, you don't want to talk about this. You don't want to, you just kind of skirt on the rug. You just kind of hope it goes away, or, you treat it and then it comes back. And in the setting of people who may suffer from recurrent perianal fistulas, drainage, or problems from below, it could be a sign of Crohn's disease. Next slide, please. So we talked briefly about the symptoms, and irritable bowel and the inflammatory bowel diseases, there's a lot of overlap, right? Like abdominal pain, cramping, the changes in the bowel movement. But when people suffer from Crohn's or ulcerative colitis, they could present with bloody stools, a lot of fatigue, maybe because of an anemia. If you're not absorbing, because of inflammation, you're not absorbing iron, you're not absorbing B12, you're not absorbing vitamin D, then this could all be a part of that. People can have weight loss because they're not absorbing their nutrients or their calories. Or people could also present with a bowel obstruction or blocked bowel because of those strictures or narrowings. Next slide. Now, the other part of it is in these symptoms, it's relapsing and remitting, meaning that you can develop symptoms and then they go away, and then they can come back again. And they do this yo-yo in people. And we don't know what can trigger a flare. Sometimes there's no rhyme or reason of what can trigger a flare. And it's what we call a relapsing and remitting course, where it comes and goes. So people can have normal periods where they feel just fine in between. But when they get these symptoms and they continue to recur, this is when we have to think about potentially an inflammatory bowel disease. Now, oftentimes we ask, what causes this? And we mentioned that there's a few different things that we suspect are a culprit here. Genetics, inherited genetics are a culprit. We do right on the right here, this picture shows currently the genes that we have identified in our research that are related to this. And what happens is we think there's actually a combination of things happening. Maybe somebody may have the genetics for this, but then something in the environment triggers a gene to either turn on or turn off, and it leads to this cascade. The other environmental triggers is smoking. Smoking is actually, it can be worse for people who have Crohn's disease. They can have a worsening outcome of their disease. Environmental pollutants. We don't know exactly what triggers this, but because we're seeing that it's something that we're noticing an increase with globalization, we know that there's something in the environment that we're just not quite understanding that could be a trigger. And then foods. Certain foods are also, we think, a culprit here. We have in our world today a lot of processed foods, right? Foods that are made with preservatives. And we do know that sometimes we do actually have data to show links between preservatives and foods high in preservatives and inflammation in the gut. So there's a combination of these factors of why people may develop this. It's not something that somebody particularly did to themselves. Even people who have maybe the healthiest lifestyles could develop this, unfortunately. Next slide, please. So diagnosis, and Patrick, this comes, no, Kevin, I'm sorry, this comes a little bit to your question that you asked, how we diagnose this, and it can get very tricky. I noticed, and there was a study that came out showing that there is a delay in diagnosis of Crohn's or ulcerative colitis for some people up to 2 to 3 years, because of access to care or just the diagnostics and not understanding how somebody can present and how, and making this diagnosis. It's a combination of endoscopy, imaging, and pathology. Pathology is the third key. right? And particularly on pathology, making sure that we see evidence that there's some chronic inflammatory pieces in there, on those slides that really help clinch for us this diagnosis. And it's not the same for everybody. It's different for others. Everyone is a little different. I diagnose this sometimes with colonoscopy or upper endoscopy. We may use imaging studies like a CAT scan or a barium swallow, or MRIs. And then we have another modality which I use a lot in helping in diagnosis or monitoring disease activity, called a capsule endoscopy. And this is where people swallow a little camera that takes about 50,000 pictures of your small intestines, and it creates a video for me to watch and look for inflammation, because our scopes, when we do upper endoscopies or colonoscopies, we can only go to a certain degree, a certain length, right? 3 feet in the colon and about 2 feet in the upper endoscopy. So we're not looking at the rest of that small intestines. So a capsule endoscopy could also be a very helpful modality in treating. One of the newest technologies we have now is something called intestinal ultrasound. There's a lot of data that's been coming out about this over the last year. It's been adopted a lot more in Europe and Canada. We're starting to see it more come to place here in the United States, where we can use a bedside ultrasound to help look for inflammation. Next slide. So treatments, and I'll go into a couple of slides about treatments. So an irritable bowel, we didn't really talk about this too much, but people who may suffer from irritable bowel, we talk about dietary changes, fiber, maybe using certain medications to help people have a bowel movement or to slow things down, exercise. Managing stress is very important in irritable bowel. When it comes to inflammatory bowel disease, a whole different entity here. We use combinations of medications where we may use anti-inflammatory medications or pills. We also have medications that suppress the immune system from attacking itself, right? And this is very common now. You may all see commercials on the TV of things like Humira or Entyvio or Stelara, and these are medications that are what we call biologic medications. And I have another slide where we'll mention this a little bit further. Sometimes we may need to use steroids to help control that inflammation. And traditionally, for many years, that was our mainstay of therapy. But there's been a shift in that because of our technology, where I am very rarely now using steroids if I don't have to, just because side effect profiles for steroids and the safety profiles for steroids are just not great. So we have better drugs and better technology now that can help bridge that. And then in patients who unfortunately are just refractory to the medications, they're not responding, or their presentation is more severe with a stricture or a fistula, those internal connections, surgery may be required.
One quick point, this is a great slide. So IBS, IBD. IBD clearly mentioned imaging, histology, and I forgot what the third thing is, but IBS, we clearly don't have imaging histology to make that diagnosis. So IBS is strictly a clinical diagnosis, correct?
Correct.
Okay.
There is a particular criteria that we use in the diagnosis called the Rome criteria, and it's part of our guidelines in how we practice. So we have a lot of published guidelines on this. Now, though, still, in somebody who may present with an irritable bowel, and depending on their symptoms and what's going on, because everybody's a little different, I always want to check. There is certain things that I do check in people. For example, if it's an older patient, I may want to check blood counts. I may want to check a thyroid level. I may want to check
Connection
here. So I may want to check things like that. In patients who may have a lot of abdominal pain and they're not necessarily responding to some of the initial measures that we recommend, I may want to get a CAT scan or imaging study as well. So it really depends on the scenario. But you're right, in inflammatory bowel disease, we use our diagnostics, we use our pathology in confirming this diagnosis. Yes.
Dr. Ali, can I ask a quick question? Similar to Cologuard, which is a DNA test for colon cancer, is there such a testing that will discriminate between IBS or inflammatory bowel disease, or even separate ulcerative colitis from Crohn's?
Very good question. So we do have a stool test that we use. Actually, I may have it in one of the upcoming slides. It's called a fecal calprotectin. And a fecal calprotectin is essentially an inflammatory marker that we can use to assess intestinal inflammation, a little bit more specific to the gut. Now, this is very similar to in practice, some of us use certain blood tests like something called a C-reactive protein or an ESR, or erythrocyte sedimentation rate. These are markers that we use to assess for inflammation in the body, but non-specific. It tells us there's something wrong, but we don't know exactly what it is. Now, in Crohn's and ulcerative colitis, we use those tests as well, but we also have this other third test that's a relatively newer test that measures inflammation. It's a stool test, and we can measure inflammation in the intestines, in the GI tract, particularly the colon. We can't tell the difference if it's between ulcerative colitis or Crohn's disease. The only way we would know that is with endoscopy, imaging, clinical presentation. But we also can't tell the difference if it's specifically for Crohn's or ulcerative colitis and a GI infection. It's still non-specific, but it tells us a little bit more in terms of gut specificity.
I imagine you get a couple samples, a couple different times.
Yes. And there's even some labs out there. If people look online, they have what we call Crohn's diagnostic labs and ulcerative colitis diagnostic labs. I don't recommend them. There's just not enough data in the literature to support them, and they're very expensive. So next slide. So I mentioned here about some treatments briefly. Now, your treatment for IBD really depends on your symptoms, your extent of your disease. And, we usually can, in something like a mild case of ulcerative colitis, where the colon only is involved, we could use things like medications out there called mesalamine or sulfasalazine. Again, mild and only in the colon. If you have inflammation in your small intestines related to Crohn's, it doesn't work. Steroids were very common to put out a fire, and we used to use this a lot, 70s, 80s, 90s, early 2000s, and we still use it today, but just not as much. And the reason why is because of its side effect profile. It can cause bone issues. It can cause mood lability, sleep problems, weight gain, worsening blood sugar levels, increased risk of infections. And we can never use this long-term. Okay. I used to meet people, I still meet people today, unfortunately, that have been on steroids for years because it's the only thing that treats their Crohn's or their colitis or their autoimmune disease. But then, unfortunately, they've developed osteoporosis of the bones or some sort of other problem. And we really don't use it. It's not really incorporated too much in our guidelines anymore of a standard of care. For long-term use, we don't. We need to bridge to something else. So what we bridge to are medications that help prevent your immune system from attacking itself. And these are called the biologic agents. And these are medications that I have listed down here, some of the popular ones you may see on TV commercials like Humira, Stelara, Remicade, Entyvio. What these are essentially are proteins that look like your body's own proteins. They're engineered to look like an antibody, and they're usually injection medications or infusion medications. So they have to be administered through the IV, through the bloodstream or through the body, because the proteins are large, so they can't get absorbed through the GI tract. That's why we don't have many pills. And they bind to receptors in your immune system to make the immune system think everything is okay, to allow your body to heal. So these are some of the medications that are now considered the standard of care in how we treat Crohn's and ulcerative colitis. And they're also FDA approved for children. Some of these medications are approved for children. We have to put kids, really early in life on these medications to help control these symptoms. Not always, but sometimes we do.
Do you find that one works better than the other, or they all are?
So I find that we've got about 20 years of experience with biologic therapies. And in the beginning, unfortunately, we did not have a lot of head-to-head clinical trials comparing one drug to the other. We're starting to see it now. In the last couple of years, there's been a couple of published studies looking at one biologic versus another biologic. What I could tell you is that they're all relatively, they're all safe and they're all effective. They're more effective than like a placebo, right? And why we would choose one versus the other may be based on clinical presentation. It may be based on the circumstances of somebody's life. If they're somebody that they travel a lot and they may not be able to come in for an IV, or response. Sometimes these medications don't work and we have to try something different. So, but they're all quite effective.
Excellent. Dr. Sprott. You're muted, Dr. Sprott.
Yeah, all these medications that you have on screen, the chemical name ends with MAB, which is monoclonal antibodies.
Mhm.
And
You're right.
you didn't talk about the expense associated with it, because, you know, with almost all monoclonal antibody therapies I know of, are, when I say super expensive,
I know.
not only do they have to be given in special places, but super expensive. What's the cost of some of the annual treatments?
Thousands, tens of thousands. They're expensive. And, you know, cost is a whole separate issue. I could talk about for an hour, and it's unfortunate, but these medications, they're expensive because they're IVs or they're injection-based therapies. And what's happened is not until recently, when a drug is developed and a drug is released, that pharmaceutical company has the trademark on that drug, right? They've got the patent on that drug. So we do not have generics for these drugs. Until recently, until the last couple of years now, a year or two, we're now seeing generic-based therapies. We don't, because of they're called biologic drugs. We can't use the term generic. We use the term in our world of biosimilar. So biosimilar drugs are bringing the cost down. And actually, by the end of this year, by December, we're going to have 20 new biosimilar drugs that are going to be introduced in the marketplace that's going to be driving the cost of these medications down. But you're right, and I don't agree with it. It is they're expensive.
You know, because you as you said, you're not talking about pharmaceuticals, if you will. You're talking about antibodies that our bodies make. So it's not like someone has a patent on the ability to make antibodies. Some kind of animal or human has to make the antibodies. So it's not like a drug. And that's why they're so specific.
But they are drugs still. They're just drugs that look like antibodies. They're mechanically engineered to look like an antibody. They're part made from mice or from human as well, but they have a patent on it. So it's considered a medication because it goes through that whole process of the FDA approval.
I don't want to get into a war on words, but the issue of clone means it's exactly the same as an antibody, right? It's so.
Sure.
Right, but the function, I think the function is,
for me, it's like the same thing as giving insulin. Our body makes insulin. It's not like the drug company had to go about and make a chemical called insulin. Our bodies make insulin. Same thing with epinephrine.
though. I mean,
No, I'm just saying, same with epinephrine. You know, like we used to give epinephrine shots for asthma, and then they make epinephrine shots for allergic reaction. They want to charge $1,000.
Yeah, true.
Yeah.
All right. What we have now is we have a dilemma because we're running out of time, but I don't want to cut this short. What I'm going to do is this is what we're going to do. Dr. Anderson, I know you have a question. We'll come with your question, then Dr. Laluya, and then we're going to gracefully end this webinar because it's been exciting. Number one, number two, such wealth of information. Number three. We're going. I just love it. So, Dr. Anderson, you're first.
Yeah, I think this requires a part two. But for Dr. Mazur, Dr. Ali, this disease, this spectrum of disease can affect anyone throughout their lifetime. And can you speak to, the physiology of cancer development, how this chronic inflammatory conditions influence the development of colon or even other GI cancers, and how does that influence screening?
So, Dr. Anderson, I'm glad you asked that question because it's also the benchmark of why we need to treat these patients. Now, sometimes inflammation doesn't necessarily correlate with disease activity, but what we use as a standard of how we treat these diseases is we want to make sure that that colon, that lining is healed. And the reason for that is because there's a high cell turnover in the colon, in the GI, in the gut. And that high cell turnover in the setting of inflammation could lead to a mutation. When people have uncontrolled active inflammation in the colon from a colitis, after our literature tells us after 8 to 10 years of disease, their risk of colon cancer goes up significantly. So much so that in our guidelines, when somebody has ulcerative colitis, if they've got left-sided ulcerative colitis or pan-ulcerative colitis after 8 years of disease, they get a colonoscopy every 1 to 2 years because the mutation risk is so high. And the risk of colon cancer is much higher. It can be in some people as high as 20%.
Excellent, excellent. All righty, Dr. Nelson Aluya, yes.
Yes, so thank you so much, Dr. Ali. I mean, it's incredible. The last statement you just made, it's one of the things that those in the primary care world need to understand and know so that they can advise their patients with, inflammatory bowel disease to go get a colonoscopy 8 years after the diagnosis. It's so important. Now, one of the things that's paramount to understand that the mouth is a pathway to the entire body. And from what you just said earlier on, Crohn's disease can affect from the mouth to the rectum. And the mouth is a huge reservoir for, protecting infection. We have all the channels from Peyer's patches all the way down to the rectum. And that's exposed to antigen from the outside. So we truly still do not understand how inflammatory bowel disease occur. But like you said, environment, genes, and everything else. But one of the particular thing that is really disturbing, especially for somebody of color, is that we begin to see this increase in the Black community. However, for those who are in Africa, it's not common. It is not. You still do not see it. Some studies that came way back from the last 20 years, 25 years, comparing Blacks, most of the research came out of South Africa, comparing Blacks in South Africa to whites, the incidence still remained 1% in Crohn's disease among Blacks and 3% among Black population, among Blacks in South Africa for ulcerative colitis. So when you ship that here to the developed world, now, ironically, the whites who are in South Africa actually still have the same incidence as the whites in the Western world. So again, genetics play a huge role. Food plays a huge role. Now, as we see the whole issue moving across the globe, we begin to find out that the food that we eat plays a huge role. Refined sugar, big time. So if there's anything, like we always say, and I talk to my people, look, especially those of us who are from African continent, stick to your diet, stick to the food that you're used to eating. I swear, because a whole lot of things are coming up and we have no understanding of power in controlling it. Food that is based on plants, food that is based on high fiber and all that is huge. Now,
Genetically modified.
Yes, so there's a study that was done about 15 years ago where they took African Americans, 10 of them, and 10 people from Africa. And they did a colonoscopy and reviewed their GI tract, but found out that the GI tract for the African, the villus, the wall was seriously really thick and lustrous and all that. But you compare that of the African Americans, it was a whole lot more flattened. So what they did the reverse, they gave them the different kind of food for 6 months.
Wow.
And they came back to do the GI endoscopy again and found that the African who now started eating Western food have blunted VI. So this is a really huge for us. So we need to pay attention to those things and the risks that are coming up. So genetics, environment, epigenetics, listen, They're here, and we must.
Actually, I'm glad you mentioned that. I have a slide in this about diet. I actually gave a talk about this last month at one of our physician conferences. You know, diet, I think, plays a big role, and it's unfortunate that, you know, we think about these drugs, and these drugs have worked great, and that's wonderful. But you know what the reality is, and it's unfortunate, and I hate to say it, is that we have not put an emphasis on diet in our research. That is the problem. When we look at the studies that have been published in all of these new drugs, these pharmaceutical drugs that have been, you know, about monoclonal antibodies, and it shows how effective you are, that's wonderful. But you know what? The best study that we have to date on Crohn's and diet is something that was published 2 years ago in 2021 with 156 patients using something called the Mediterranean diet, and actually was very effective. But that study, even though it's the pinnacle of what we've got so far, it's nothing compared to what some of these pharmaceutical companies are doing with their drug studies. And it tells me that, and the other part of it is there's no diversity in the study.
Right.
There's none. It's you know, it's primarily, you're not seeing multinational, multiple races. So unfortunately, we just don't have the data. But I do feel that food is medicine, and I do strongly agree with you that diet plays a critical role in how somebody develops this, how people are being managed, because we do know diet can help as an adjunct to the medications.
Excellent. You are what you eat. I tell my patients that all the time. You are what you eat. Dr. Court, please, and then Dr. Atherley. We got to
wait real quick. My question to Dr. Ali is, since these two conditions, ulcerative colitis and Crohn's, have a potential to become cancerous, what is your screening protocol? Is every 5 years that you screen the patients that you see, or what?
So when I make a diagnosis, sometimes I bring them back after a year or two, even, to make sure things are healed. And every year, at minimum, I'm seeing them. If my patients are on any of these biologic-based medications or medications that suppress the immune system, every 6 months, if they're feeling great, more if they need to see me. But I may do a colonoscopy every 2 to 3 years, just to make sure things may be at bay. But then when they hit that in ulcerative colitis or Crohn's colitis, when Crohn's affects the colon itself, after 8 years of disease, then there is a change in the requirement on the screening protocol, where it's every 1 to 2 years.
Excellent, excellent. Dr. Atherley, and Dr. Atherley, are you muted? I didn't hear you.
Can you hear me?
Yeah, we can hear you now. Yes.
One very quick question for our excellent discussant. I really am impressed with the nature and the level of the discussion. But one of the common things that patients present with to all of us is pain. And so often abdominal pain in the belly, may be thought and evaluated purely for a gastric cause or intestinal cause. Up to recently, a few days ago, I saw a patient who had been treated for abdominal pain, et cetera, et cetera. Turned out that when we evaluated him further, he had a 95% blockage of one of the most important arteries in the heart. In other words, he was on the verge of a fatal heart attack. So what are the clues you can tell us or tell the patients who may present with pain, a universal symptom, pain in the belly, to start looking elsewhere, or I should advise them to seek other organ systems for the evaluation of that pain?
So I think this is important, because when somebody has abdominal pain, there's clearly something going on, right? And it could be something as simple as maybe a bowel irregularity from irritable bowel, stress related to that. It could be something with affecting the blood vessels that are supplying the blood supply to the digestive tract. It could be something more severe, or something related to the gallbladder or the appendix, inflammation. So I always advise, if there is abdominal pain, if it's something that is recurrent or chronic, right, then definitely seeking physician or healthcare professional advice, because it may require additional imaging. It may require some lab work. It's not normal to have abdominal pain, right? So, and it could be something simple like a dietary measure that could be fixed. But unless we get in, we meet with that person, have that discussion, really do a proper evaluation, including a physical examination. Physical exam is extremely important. Then we wouldn't know how to help them. So I do recommend strongly that they do seek our help.
But
If I,
the,
if
the
I,
patient may have had risk factors for heart disease, other risk factors.
so if I may add something to that quickly, Dr. Ali, when you started, you said that inflammation of the joint, or chronic inflammation of the joint is rheumatoid arthritis. The same of the stomach is Crohn's disease and all that. Now, we utterly know that for those with rheumatoid arthritis or joint diseases that are inflamed, they have a 20 to 25% chance of inflammation across the entire system, including the heart. So that risk is also increased with atherosclerosis or heart disease. So it's the same thing with ulcerative colitis as well.
Correct.
Inflammatory processes increase the risk of you developing inflammatory changes in the heart, in the arteries, and everywhere else, and that puts you at risk for heart disease.
Absolutely.
Excellent. This is such a great discussion, but we're going to have to bring it to a close, unfortunately. Boy, this was great, Dr. Ali. I'm telling you, we're going to have to maybe not, commit the whole webinar, but I'm sure going forward, we're going to have a lot of GI questions to ask, and looking forward to your answers. Definitely.
Yeah,
I'm
this
happy-
requires a part 2.
Yeah. Oh, yeah. This is good. This is good. I mean, and it's so
Or
necessary.
part 3 in Guyana.
Part 3 in Guyana. Yeah. Very soon, Dr. Court. Very soon.
2 weeks.
All righty. So let me end by saying, and as in closing, thank you, OBHealthy, for allowing us to bring this platform to the world, I will say. And because without them, we couldn't do this. Our webinar is every second Saturday at 1 o'clock. And please let family, friends, church members, everyone know that we're here. We're willing to answer as many medical questions as we can. And we're going to try each time to pick a topic that we're going to dive into and just give some great education out there. If you want to revisit this webinar or any other webinar that we've put together, they're all on YouTube. All you have to do is go to obhealthy.com and hit the YouTube channel and view those webinars. I'm telling you, they're worth going to see, going back to listen to. As I talked about sharing and caring, let other people know. The most important thing that I can say, and I've said it twice, and this is the third time, please do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you appropriately. All righty. And other than that, we're going to see you next month. Same time, same station. All righty. Please have a good month. Peace. Take care of yourselves. We'll be here to answer your medical questions. Dr. Ali, thank you.
Thank you for having me.
All righty. Take care, everyone.
Goodbye, everyone.
Bye-bye.